Good evening, everybody. We'll just give it a moment as everyone makes their way in. Happy Monday, Dr. Offerdahl. How are you today?
Thanks. Happy Monday to you. I'm well. Semester started with the optometry students today, so busy day. How about you?
It's good. It's another Monday in private practice with a flood in my office yesterday, but we are making it. Everyone in Connecticut, hopefully, if there's anyone joining us, hopefully everybody's safe. We had some flash floods and some crazy weather. So
God,
it's been a Monday. So,
yeah.
but I see that we've got a lot of people that are making their way in, and to be respectful of everybody's time on this Monday, I'm going to kick it off. Welcome to tonight's Wu University event. Maximizing Antioxidants in Eye Care with Dr. Tracy Offerdahl. I'm your host, Dr. Jennifer Stewart, and thank you to Pharmanex for exhibiting at tonight's event. So just some reminders: for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. There will not be a QR code tonight, so you can keep your phones down. You don't have to pull out your OE tracker app. But if you're here and you're here for the right amount of time, you will get your CE certificate delivered by email, and that will happen within 4 weeks. Throughout the presentation, feel free to ask questions using the chat and Q&A. We'll leave time at the end, but you can ask your questions throughout the presentation, and Dr. Offerdahl is really great at looking at those throughout, so don't feel you have to wait till the end. If you're on a mobile device, you can find Q&A at the top and find chat. We're under those 3 dots. It's my great pleasure to once again, I think this is our 5th time at least presenting together. It's always my great pleasure to introduce Dr. Offerdahl. She attended Temple University School of Pharmacy in Philadelphia, PA, for both her undergraduate and graduate degrees. Upon completion of her Doctor of Pharmacy degree, she completed a residency at Temple University Hospital. She's currently on faculty at Pennsylvania College of Optometry at Salus University in the Department of Optometry, where she's the course director and instructor for all systemic pharmacology courses for students in the optometry, audiology, and physician assistant programs. Additionally, she's a practicing clinical pharmacist, and she's a fellow in the American Academy of Optometry. Welcome once again, Dr. Offerdahl. We're happy to have you. We're excited for tonight's presentation, and I'm going to turn it over to you.
Thank you so much, Dr. Stewart. Appreciate it. Well, welcome everyone to this Monday night discussion on maximizing carotenoids in eye care. It's certainly a timely discussion, and we're going to get going here. Let me get us going from the beginning. So you see my email there. Certainly email me if you have any questions, and if you're able to join us in the breakout room afterwards, we'd love to have you for further discussion. It is, just as you know, a 1-hour CE. So if you've ever heard me speak, I'm a fast talker to begin with. And this is such a broad discussion. And there's just so much involved that I'm gonna keep you awake and move along at a pretty quick clip here. My financial disclosure, my disclosures in general have already been mentioned, but I'll just finish it off by saying the only thing I have is a non-salaried affiliation agreement with Pharmanex, and all financial relationships have been mitigated for the purpose of this program. I will be talking about, quite a few products and medications, and I'm not claiming superiority of one over the other. So let's jump in here. What I wanted to kind of build here was the reasoning behind carotenoids and antioxidants in general. And of course, you already know most of that, or a lot of it, because you use them in your patients as optometric physicians all of the time. But what I wanted to build further is the reasoning behind why thinking outside the box as it pertains to carotenoids, not only the actual supplements themselves, but how we can measure antioxidants. We've got macular pigment, we have antioxidant measurement you can do on your fingers, and then of course we have skin carotenoid antioxidant measures as well, and then more of a comprehensive approach to treating or treating our patients, I guess, but more supplementing, optimizing our patients and their individual bodies. Because by doing that, we're also going to impact their eyes for sure, right? Just the same way of thinking as many of the diseases that you see in your patients in their eyes are end organ disease. We can support the body and stabilize some of those diseases and conditions and prevent further diseases and conditions. So it's really a win-win for everyone. So a lot of this stems around autoimmune disease, and you know that the immune system plays a large role in, glaucoma, macular disease, et cetera. But it also plays a large role in many other diseases in the body. So, we sort of tongue in cheek, and if you've heard me speak, I may have used the slide, but choose your parents wisely. It's kind of like, ha, 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 can't really do that, right? So I just want you to have an understanding of what you have control over, what your patients have control over, and how you can educate them in this regard. And so this slide is basically telling you that, over the course of our lifetimes, about 8, 10, 12%, whichever number you wanted to use, 8, 10, 12%, I have 8% here, actually comes from our parents. So certainly things like hair color, eye color, body structure, things like that. And even some of our risk factors and diseases come from our parents as well. We know that there are certainly loads and loads of different diseases and conditions and problems that come from our DNA. But I want you to notice the landslide of 92%. So if you say 12% comes from your DNA, from your parents, we could say 88 to 92% we have control over. So some of that can be lifestyle choices, some of that can be dietary changes, some of that can be mindful meditation, rest, exercise, all of these things. But a lot of that isn't enough. And the other component that we have to consider certainly is what we eat, and eating well-balanced diets full of lots of fruits and vegetables and rainbow, the rainbow of colors. But we also have to take into consideration that we don't absorb things as well as we should. And that is true across the board. Of course, there are going to be some exceptions to that, and we can generally try to improve our absorption with maybe pre, pro, and postbiotics. That's a whole different discussion. But I just want you to understand that, when patients say there's nothing I can do about it, my dad had a heart attack, my mom had cancer, my brother had a heart attack, he died young. Well, there may be a genetic component to that, but many times the patient has a lot of control over what happens. And that's kind of what we're looking at today, looking at what we can control in our own bodies and in our patients' bodies, things we can turn off and, turn on and turn off in terms of gene expression. So a lot of this plays also into the DNA sciences. Genomics is looking at all of our genes. Genetics is looking at individual alleles that are coming. If you're looking at pharmacogenetics, it's looking at an individual allele that's coming from a parent. And you already utilize some of this. Many of you probably do, because you are already pharmacogenetically testing or genetically testing. It is really pharmacogenetically testing. If you do any ARMS testing for age-related maculopathy susceptibility to, or complement factor H. So I have the letters backwards here, or switch, sorry about that, but it's complement factor H. We're going to talk a little bit about this because this goes hand in hand with the discussion on carotenoids, and very specifically the lutein, zeaxanthin, maybe mesozeaxanthin if you're using a product that contains that, which is fine, and whether or not you use zinc at all or the level of zinc. You're already doing this in your practices. So the discussion we're going to continue is, well, what else can we do, and how do we make these decisions? The epigenetics is really where we get a little sticky in some cases, because the epigenetics is really the study of how our cells control gene activity without changing the DNA. And it has everything to do with our external environment and also, our internal environments. And we have a great amount of control over a lot of those things. I already mentioned some of them. And then our exposome is really the measure of how our exposure to all of these individual and lifetime exposures, I guess, to repeat it, how they relate to our health. So we know as we are dividing cells in utero from, 1 cell to 2 cells to 4 cells to 8 cells to 16 and so on and so forth, already we are being exposed to things that we shouldn't be exposed to, sometimes because people don't know that they're pregnant, or because, they have to live in an area where they're exposed to unsafe drinking water or whatever. So there are a lot of things that by the time we're an adult and we can make decisions for ourselves that we've already been exposed to. There's not much we can do about that. But it's what we're doing now to sort of halt progression of some of these things and change what our future will look like. We are made to be self-healing organisms. Wherever you think you came from, we are created to be self-healing organisms. And our homeostasis is a very short blip in the eyes of the human body. So unfortunately, as self-healing organisms, we have really dorked that up over time, particularly in the Western hemisphere, so to speak. It's a shame, but it also tells you, as much as we've been able to dork up our body and our exposome and everything included, that means that we have some control over our ability to fix it, for sure. So a lot of this stems from oxidative stress, right? Those reactive oxygen species. And this is sort of looking at just a visual picture, a graphic picture of some of the problems involved in our exposome. All of these contribute to free radical formation. And we'll talk just briefly about that in a second. This is just looking at it in a different way and how these things contribute to autoimmune disease. But of course, here are our genetics, so maybe, 8 to 12%. And I'm not saying that there are not certain types of problems, diseases, maybe cancers and other things that are absolutely tied to genes. I'm not suggesting that. I'm just suggesting that as a gross generalization of all things thrown into a basket, we have a lot of control over what happens to us. So we have genetics, infections, and whether or not people had antibiotics, our gut microbiome, or, specifically looking at gut dysbiosis, toxic chemicals, dietary components. I mean, you even have to throw in here, emotional well-being and things that contribute to stress with cortisol levels, et cetera. But all of these are part of the puzzle of autoimmune disease. And of course, macular disease and inflammation is certainly part of that. So here's the quick rundown, very quick. I don't know what this blue box is. Sorry, it must be an errant text box. But what I want you to see here is just what exactly is a free radical. Many of you probably know exactly what it is, but our body's health is dependent upon what our cells look like. So our cells' health. And in order to slow down chronic conditions and diseases and things that, truncate the length of our life, we can have some control over this by really thinking about oxidative stress and how we can mitigate that oxidative stress. Or, you can't ever get rid of it completely, but you can down regulate it extensively. So here are atoms. This is a healthy atom. It has 2 orange dots. These are paired electrons. That is what we want. So we have, things that we eat and other mechanisms in our body that can take a free radical, which is simply an atom that is missing one of its electrons. That becomes problematic in the body when we have a lot of those. We need a pool of protection. And you are already doing that in your patients if you're supplementing for, retina health with the macula, et cetera, with lutein zeaxanthine or whatever you're using. Those are obviously just some of the biggies in your realm. We have to have enough antioxidant protection in order to try to give enough of electrons to all of these free radicals. Because here's really the long and short of it. If we have cells that are full of lots of atoms that are healthy, then when our cells are replicating, which they do all the time, then our cells are replicating healthy cells. And the more antioxidant protection, the more carotenoid and antioxidant protection we give ourselves and our patients, the more likely we are to be replicating healthy cells. And we are decreasing our chance of having lots of different problems: cancer, dementia, heart disease, other autoimmune diseases, rheumatoid arthritis, lupus. I have those too, but I'm in full remission on no medication. Macular disease, glaucoma, thyroid eye disease, thyroid disease. The list just goes on and on. Because on the flip side, if we do not have enough antioxidant protection systemically, then when we have unpaired electrons what we call free radicals, and we have a lot of those because we don't have enough antioxidant protection to fix the free radicals and make them back into paired electrons and a healthy atom, then we now have cells that are unhealthy, and those unhealthy cells replicate more unhealthy cells. So cells are going to continue to replicate no matter what the state of those cells look like. And it's when we start to have this dysfunctional cell replication and mitochondria damage that we really start to see over time this slow burn inflammation, this slow burn subterranean inflammation that really is what's contributing to autoimmune diseases and conditions and other problems. So that's what we're seeking to fix here. So here's what I just was saying: low-grade inflammation, slow burn diseases. With this inflammation, we see cancer, pulmonary diseases, neurologic diseases, other autoimmune diseases, arthritis, macular disease, type 2 diabetes, Alzheimer's, cardiovascular disease, etc. Lots of different problems that we see from this slow burn inflammation or slow burn diseases. So we can't get away from this discussion without just running through some of the biologic medications. So we have lots of biologics, right? We've had insulin for a long time. We've had blood products. We've had vaccines. They're all biologics. So biologics are these amazing structures. They are genetically engineered medications that treat diseases and conditions for which we have no other options, or we have maybe options that are kind of good but don't work for everybody, or are not big gun enough to really get the job done in certain diseases and conditions. So the other issue with biologics is we call them reference products or innovator products. The biologic itself, that's sort of what we consider to be, and I'm using air quotes, the brand name product, even though we can't really truly kind of say that. You'll see why here in a second. So there really is no such thing as a true generic biologic. So let's name a few, and we'll run through them here in a minute too. But like teprotumumab, Tepezza for thyroid eye disease, or Cenegermin, BKBJ, Oxervate for neurotrophic keratitis. Those are some of the biggies that you see. Even the anti-VEGF meds that you use for AMD, certain types of AMD. All of those are biologics. So those are the first products that have come out that have been discovered for these conditions or diseases. And when the patent expires on Tepezza, on Oxervate, on Macugen, then what comes out next is a biosimilar, not a generic. There is no such thing as a true generic. I mean, generics are exact copies of the other drug, the brand name drug, right? So if you have, let's see, Xalatan, we'll use that. We'll stick with eye products. So you have Xalatan, that's the brand name, and then you have tons of generics. I don't know, 15 different manufacturers of latanoprost. That's problematic in and of itself, but that's a different discussion. With a biologic like Tepezza or Oxervate or Macugen or Remicade or Actemra, et cetera, you're never going to have a true generic because these come from living organisms, and what you will end up with is what we call a biosimilar. And a biosimilar just is, as close as we can get. It's highly similar. Only the government could come up with a description like that. And there's no measurable difference between safety, purity, and efficacy between the biologic and the biosimilars. And we have a lot of these products out as well. So again, kind of working with this autoimmune type discussion, that's why I'm going to run through these and just remind you of some of them that are available. Because not only do we have things in our exposome like toxic chemicals. I mean, I saw a guy the other day spraying Roundup on his weeds with shorts and flip-flops on. I mean, you even say Roundup and I'm running the other direction. I want nothing to do with it. I don't even want to think about it. It's, glyphosate causes cancer, all kinds of problems. I don't use it, et cetera. And I rolled down the window and made a citizen's arrest because I was like, dude, what are you doing? It's spraying all over your legs. So that's part of his exposome, which is going to be a disaster short-term and long-term. that's something that we can control. But when people have to go on medications, and it could be anything from what we call small molecule chemicals, Lipitor for their lipids, carbonic anhydrase inhibitors for, maybe to help lower IOP when topicals aren't enough. And then they're on something for heart failure. Then they're on something for blood pressure. They're on something for this, that, and the other thing. That is another thing that is another parameter of our exposome that is causing great oxidative stress in our patients. So monitoring parameters for biologics. We know that many of our biologics, they're all immune modulating, but they're not all immunosuppressive. This would be an immunosuppressive biologic like Actemra or Humira. So Actemra for giant cell arteritis, Humira for uveitis, certain types of uveitis. So PPDs are placed ahead of time to make sure you don't have latent tuberculosis. You can get horrible infections because they're immunosuppressive if you're exposed to COVID, the flu, a common cold. And patients have to really be careful whether or not they take a dose based upon how they feel and other medications that we're using. Why do we use them? Why are they here in this discussion about carotenoids? Because our patients that use biologics are patients with autoimmune diseases many times, most times. And we see cases of thyroid eye disease, rheumatoid arthritis, psoriatic arthritis, giant cell arteritis, polymyalgia rheumatica, macular disease, macular edema, uveitis, keratitis, etc. I could rattle on for 5 minutes straight with all of the problems that we see treated with biologics, cancer. So all that leading us to, the discussion as to why people need, if you haven't been convinced, even just with, family history of macular disease or, patients with personal histories of macular disease, there's so much that is playing into the autoimmune component that we have to consider outside of our own realms of what we do professionally. So look at these targets, look at these antibody targets, all of these chemical names of biologics, anakinra, basiliximab, daclizumab, that one's a tough one, mepolizumab, tocilizumab, etc. These all target different antibody receptors. Some of them are interleukin inhibitors, some 1, interleukin 2, some of them are T lymphocyte inhibitors, some of them are interleukin 6, interleukin 12, 23. We have tumor necrosis factor inhibitors. We have insulin-like growth factor 1 receptor antagonists like teprotumumab, Tepezza. What is the common thread? These are used for rheumatoid arthritis, kidney transplants, relapsing MS. I mean, so many different indications on this particular slide. But what holds them all together is this autoimmune component. I mean, even if nobody has autoimmune disease yet, everybody has some degree of this slow burn inflammation, these slow burning diseases or conditions. I mean, I can pretty much look back on my life and figure out what probably caused me to finally, move into full-blown lupus and rheumatoid arthritis. And, it was certain things in my exposome that I didn't have control over and certain things that I absolutely did have control over, but, I just was making poor decisions in terms of eating and things like that, starving myself. So we are able to augment some of the things that happen to us. So we have to throw in metabolic disease, which you're thinking, how did we make a hard left turn to metabolic disease in a discussion about carotenoids and autoimmune disease? Well, there is an autoimmune component to this, absolutely. So cluster of conditions associated with metabolic syndrome, metabolic disease, elevated glucose. We measure both fasting blood glucose as well as hemoglobin A1C. What we're looking at here is insulin resistance, which is a huge inflammatory trigger. We have high blood pressure, and look, it's only 120 systolic. That's our threshold, so it's not very high before we get concerned. People who are overweight, very overweight, or extremely overweight, abdominal obesity in particular, abnormal cholesterol ratios. Notice it's only triglycerides and HDL cholesterol here. What's missing? LDL. That's actually not one of our markers, because what are we looking for here? These are components of metabolic dysfunction that are inflammatory in nature. And, LDL is certainly important to measure it and making sure that it's a, you know, normal number, so to speak, but we're not looking at it here in our cluster of conditions. And then things that are pro-inflammatory, pro-thrombotic states. If you have 3 of these things going on over here, your chances of heart disease, stroke, diabetes, dementia, cancer, macular inflammation, macular disease, thyroid eye disease, you know, Hashimoto's thyroiditis, all of these things are increased because of the metabolic conditions. We have so many people, and then I also added, just to interrupt myself, PCOS, polycystic ovarian syndrome, as well as non-alcoholic fatty liver disease. So there's a lot going on here. And it all starts usually with insulin resistance due to chronically high high normal blood glucose levels. And, you know, a lot of it is, most of it is the food that we eat, the snacks that we feed our kids, and, you know, sedate, you don't move around very much. I lectured the optometry students for almost 8 hours today. My brain is mush, so I'm having word problems. Okay, look at this slide. Don't panic. We're going to spend 20 seconds on it. But I just want to show you why you've heard so much about Ozempic and Wegovy and Mounjaro and Zepbound. This slide is entitled Pathogenesis of Hyperglycemia and Type 2 Diabetes. Notice this red arrow. So all of this is contributing to hyperglycemia and type 2 diabetes. So at the top of the food chain here is this red arrow pointing to the incretin system. I just want you to just take a split second and say, okay, so basically she's saying that if we can do something to this incretin system, then maybe we can have an impact on all of the pathogenesis of hyperglycemia and type, you know, for hyperglycemia and also type 2 diabetes. And the answer to that is, yeah, we can. And this is where the Ozempic and the Wegovy and the Mounjaro and the Zepbound and the Victoza and the Trulicity, all of those agents work. And that is why they are life-changing, life-altering, make you live better, make you live longer medications, and not just for people who are overweight or have type 2 diabetes. Notice the last 3 categories here. You're looking at glucose uptake in muscle, you're looking at kidney issues with glucose absorption, and you're looking at neurotransmitter dysfunction. Have you ever heard or read anywhere that in many research circles, Alzheimer's is called type 3 diabetes? Neurotransmitter dysfunction associated with persistent hyperglycemia, which leads to type 2 diabetes. Metabolic dysfunction fits into this discussion about antioxidants and carotenoids perfectly. All right, here are our drugs, right? There's our semaglutide with Ozempic and Wegovy. You have some of the OGs with Victoza and Trulicity. We have quite a few of them. These agents work so well to decrease insulin resistance, which results in a decrease in some of that slow burn inflammation because they work and the glucagon-like peptide 1 receptor. I just want to mention here, this was that red arrow a couple slides ago pointing to the incretin system. Glucagon-like peptide 1 is incretin. And so those drugs, the Ozempic, the Wegovy, the Mounjaro, and the Zepbound, and all the others in the group, they work on that specific compound. They make the incretin system work better. They're mimicking the incretin system. They're still drugs. The body's still like, oh no, a drug, but they really work well in most people. They tell the body to release insulin. They tell the pancreas to release insulin in response to food. How does a body with metabolic dysfunction do that? It doesn't do it well. If it did, it wouldn't have metabolic dysfunction. We now have drugs that mimic what our body did before metabolic disease and or type 2 diabetes. Most people know that these agents also slow gastric emptying, which for most people is a good thing. They do suppress the appetite and of course, improve hemoglobin A1C. They help with weight loss. Tirzepatide, Mounjaro, and its brother, Zepbound, same drug, tirzepatide, but one's Mounjaro for diabetes and Zepbound, this guy, for weight loss. This is a slight twist in the mechanism because our gastrointestinal tract actually secretes two hormones that are part of the incretin system. They secrete glucagon-like peptide 1, and it also secretes, our guts also secrete glucose-dependent insulinotropic peptide. So tirzepatide is a GLP agonist and a GIP agonist. Ozempic, Wegovy, Victoza, Trulicity, et cetera, they are only GLP agonists, which is good. But if you've heard anything about tirzepatide maybe being better in a lot of people or some people, that's the reason why. It's more physiologically similar than just being an agonist at glucagon-like peptide 1 receptors with Ozempic and Wegovy. Not that they're bad, they're great medications in and of themselves. You've heard about the side effects. I'm not going to really spend much time on these, but again, these are drugs. These drugs are being used to decrease insulin resistance, which ultimately leads to a decrease in that slow burn inflammation. But there are downsides to every drug. There is no such thing as a drug that doesn't cause problems. And of course, there have been some biggies that we've seen in the news, the gallbladder issues. People can't use it if they have a personal or family history of this medullary thyroid cancer. Poor Sharon Osbourne, you know, she looks great, but she was a good example of somebody who ended up with Ozempic face. Loss of muscle is a big issue if people are not becoming active or staying active and building those muscles with strength training and or resistance training, particularly as people age, using appropriate supplementation, whey protein supplements, collagen peptides, bioactive collagen peptide supplements, and creatine. I'll be 55 years old and I take creatine supplement every single day along with the whey protein and my bioactive collagen peptides because I lift 50-pound bales of hay and things like that. And I need to, you know, maintain good skeletal muscle mass. Everybody does. Not everybody needs to do it quite as intensive as, you know, others, but we all need that. So additional adverse drug reactions from these agents, again, think oxidative stress, so diabetic retinopathy. These agents can worsen diabetic retinopathy. We're not going to really get into a big discussion, but suffice it to say that this isn't new, by the way. All anti-diabetic agents we've known since the 90s, maybe even before that. We just really haven't talked about it much. All drugs that are improving glycemic control and lowering fasting and postprandial blood glucose, as well as hemoglobin A1C, they all have the ability to worsen diabetic retinopathy. Maybe that's a record scratching moment for a lot of people, but we've known this. It's just that it's really been in the press because of the Ozempic, Wegovy, Mounjaro, Zepbound. It is transient. With these agents in particular, it's usually occurring within the first 16 weeks of starting the medication. And then there was another one that, you know, a global gasp was heard in July 2024. So just last month, the JAMA Ophthalmology Journal was talking about an increase in the rate, fourfold increase actually, of non-arteritic anterior ischemic optic neuropathy in people. I think it was, I'm pretty sure it was specifically semaglutide. And, you know, kind of giving basic guidelines on this, like if somebody has monocular vision, any vision loss in general, or they have a history of NAION, that maybe they should cautiously use one of these GLP or GLP plus GIP agonist agents. We don't have great direction in that regard, but the more we talk about it, the more we're going to watch for it. The more we talk about it and watch for it, the more we're going to learn about it. So anyhow, again, oxidative stress all over the place, from drugs, from diseases, etc. So I said all of this, but I'm just going to repeat what we're dealing with here is just insulin resistance, which is causing this systemic inflammation. The systemic inflammation ultimately impacts the eye and causes disease there as well. And sometimes it's happening simultaneously. Many times it's happening simultaneously. So the point being, we need to consider antioxidants, carotenoids very specifically, comprehensive antioxidant and carotenoid supplementation and measurement for our patients and for ourselves. We can't forget about our biologics for choroidal neovascularization. We've got a lot of anti-VEGF treatments, which are great. They work. But what if we could try to fix that ahead of time? What if we could treat these diseases or conditions early rather than waiting until they're moderate severe, because that's the only time we can actually see that moderate severe, on an OCT or whatever. What if we treat very, very early? And we'll talk a little bit about that with the Beckman classification. So here's the oxervate for the neurotrophic keratitis, another biologic. It's a great drug. And our teprotumumab, Tepezza, these I've all mentioned. I mentioned the Humira, adalimumab, a biologic for non-infectious intermediate posterior and panuveitis. We've got our Actemra, tocilizumab for our giant cell arteritis. I'm just checking the time here. Our patients are expecting more, particularly past COVID. What did we learn? Well, we don't have time to talk about all the things we learned, good and bad, during COVID, I guess. But one of the trends that we saw, and actually, where were you when the world fell apart? I was lecturing actually with Greg Caldwell at SECO in Atlanta in March of 2020, and we were there until just a couple of days before the entire, country shut down, in the world for that matter. And we were losing participants at SECO, or attendees, by the minute. And he and I were, going to give a lecture, and the size of the crowd was diminishing substantially. And everybody was saying, basically, we don't want to talk about the subject we're supposed to talk about. What can we do to protect us against this organism? So we spent a good chunk of time with one of those tear off paper things, writing just different supplements and ways that, and doses, et cetera, and ways that you can protect yourself against viruses. I mean, it was the same protocol that he and I have used for flu, cough and cold, so influenza and everything else. That didn't really change. It's just the offending critter changed to SARS-CoV-2. And now our patients are expecting this. They felt, just in general, the whole world felt such a lack of control over their morbidity and mortality with COVID. People got a lot more interested in sort of functional medicine, root causes, holistic medicine, not just doing the drugs, but also doing things that support our bodies and maybe prevent things from happening. Maybe I won't ever get COVID or the flu because I have myself so well filled with good nutrition, good exercise, sleep, mind, body things, as well as, oxidative stress support. So our patients are expecting early detection, wellness from us, and prevention. You already have more cool gizmos and gadgets than any type of medical practitioner I've ever seen. And many of these I have no idea what they are, but a couple of them I do, with the ERG and then the OCT. And then here you have some pharmacogenetic testing for the genetic alleles that are problematic. There's a word I'm looking for that it just escapes me. But basically, when you have a genetic variation that puts patients at risk for choroidal neovascularization with high dose zinc that's in some products. So either don't use products that have any zinc or use low dose zinc. That's what we're getting here. You have so many different things that you can use for allopathic treatment, but also some of them you can also use for more of a holistic or functional approach. And then that's what we'll do here as we're rounding out the last, 15-ish minutes. So we have biomarkers. You use them all the time. You have tons of biomarkers in your offices that you use for your patients. It's just a test that has meaning. And usually when we're measuring a biomarker, and at the bottom it shows you, it could be blood pressure, blood work, heart rate, genetic testing, intraocular pressure, carotenoid measurement, macular pigment, antioxidant levels in our fingers, et cetera. All of those are biomarkers. And biomarkers are just a piece of evidence, some sort of marker that is a sign of normal or abnormal process that's going on in the body. It can also help us see how well a patient is responding to something. So that's the beauty of some of our ability now to measure antioxidants and or carotenoids, et cetera. We can actually see improvement in real time once a patient has been changing their diet and supplementing as well. Predictive biomarkers are those that are basically showing us something that is predicting disease, either progression or whether it's going to occur at all or whether it can be mitigated. So look at these. These make sense. Hemoglobin A1C, C-reactive protein, plasma homocysteine, our vitamin D levels. I mean, all of these were being looked at even for people who had COVID because from a predictive biomarker perspective, we knew that people that were less healthy, the more diseases and drugs that they were taking, people who had heart, cardiac disease, people who had cancer, people who were overweight, very overweight, or extremely overweight, they were more likely to have severe disease from COVID and more likely to die. So, these are all predictive biomarkers in the sense that they can predict outcomes in many situations, not absolute, but we know that they're tied to our people's ability to predict certain outcomes. So our omega-3 index, some of you might measure those in your patients, and then our carotenoid levels. It's a measurement that is a representation of all antioxidants in the body. I call myself a biohacker. My mom said, that doesn't sound very good when I told her I was a biohacker. And I said, don't worry, Mom. It just means that I'm controlling my environment and what I, take into my body and what I do outside of my body to control my own biology. And it's pretty cool. We can do that. And it's not that hard. It really is not that hard. So this is Dave Asprey. I loved his description the best. Somebody who uses science and technology to make his or her body function better and more efficiently. Who doesn't want that? This is what we're trying to do. Just a reminder, we've already discussed the slide, but we are trying to make sure that we have enough antioxidant protection to make those free radicals into a healthy atom. Because as you see, the skull and crossbones, that's never good. We are replicating damaged cells, damaged mitochondria, and ultimately leading to this slow or contributing to the slow burn diseases, low grade inflammation. Everybody knows whether or not we do it, but everybody knows that, the rainbow of fruits and vegetables, 8 to 10 to 12 servings every single day is what all of us need in order to get all of our carotenoids, polyphenols, this, that, and the other thing. Some we have endogenously, others are essential nutrients that we have to take from the outside. We have to eat them in order to have them in our bodies. But also consider the fact that all of these fruits and vegetables, let's look at an orange. It would take 50 oranges that were grown in 2024 from a nutritional perspective. It would take 50 oranges to equal one orange from 1950. A lot of 50s, just as an example. And I don't know how they measure those things, but they, whoever they are, have measured them. So again, going back to kind of this antioxidant protection, thinking outside the box in terms of not trying to just pigeonhole certain antioxidants in one area of our body. And all of us do that, no matter what our healthcare or medical discipline do, right? We sort of treat to what we're experts in. But there's a lot of information coming out that's showing, we don't just want to treat the antioxidant levels in the eye. We don't just want to treat the antioxidants that, or specifically look at one that's going to treat a certain thing in our body. Because the fact of the matter is we don't always know very specifically what we're deficient in. So I was a victim of my own ignorance. 5 years ago, if you asked me what supplements I took, and I took a lot, and a terrible autoimmune disease, I was on Remicade, methotrexate, Plaquenil. I had gained 60 pounds on the medications, and as part of the autoimmune disease, I felt like hell. I looked like hell. It was bad. And when all of those drugs no longer worked, I thought, what do I do now? I was taking, all the individual components, the magnesium, and I'm not saying these are bad. I'm saying that there's a better way to do it. But, the resveratrol I was taking, and sometimes I would take quercetin. I always took omega-3s, fish oils, and then I would do vitamin D3, which was, we still need to do for sure. I was like picking, right? I was just cherry picking very specific supplements because I was like, ooh, this one's good. It's a great manufacturer. It's very pure. So this is going to help me. When in reality, I was just spending way too much money, I think $420 a month. but I don't like shop or do anything else. I spend it on my supplements and all my farm animals. I felt terrible. I looked terrible. I was incredibly sick, and I wasn't absorbing them because I was measured to see what my antioxidant levels looked like. And that's when we're talking about like, macular pigment is a choice, antioxidant levels in fingers, and the skin carotenoid level, which is what I ultimately ended up using. And, still, you still see a lot of practitioners using all of these. So here's the issue. Our cells are vulnerable to oxidation. That's what this entire discussion has been about, other than what can we do about it. We've got a fat soluble vitamin, we've got our vitamin E, we've got vitamin C, so basically we have inner cell, outer cell, or you could even say, lots of different ways to describe this. Here's our beta carotene, our lutein, our lycopene. You can see them kind of, cartoonishly drawn here. But what I want you to see is that they all have a home, and everything works in our body because something else helped it. So you don't just think vitamin C is the most important because I read somewhere in, Reader's Digest that we're all deficient in vitamin C. Okay, well, that may be true, but we also have to make sure, I'm not saying everybody's deficient in vitamin C. I'm just saying that there's maybe a kernel of truth to what we read sometimes, but everything works together as a cofactor, or whatever you want to call it, to other vitamins and minerals and nutrients. So we need everything in order to make our bodies function perfectly, or as perfectly as we can get, when we've been sick for so many years, like I was. So, think of it again, outside the box as more of a comprehensive antioxidant approach and all the benefits that come from that. You already do a lot of this integrative type stuff, various supplements, maybe AREDS too. There are lots of different great companies out there. The Omegas, Vital Tears, Regenerize, amniotic membranes. You're already thinking like a holistic practitioner. We want to be able to augment the epigenetics portions of our bodies, the stuff that we have the ability to control. We can't fix our genes that we got from our parents. We're never going to change our eye color. This is again, I already showed you once, but this is again showing the ARMS2 and complement factor H that is giving you an idea if somebody's high risk for having this mutation. I'm trying to simplify this to make it shorter. Genetic mutation, that it's actually dangerous to give somebody, an AREDS2 type formula that has high zinc in it. And you can cause dry AMD to move to choroidal neovascularization. Of course, I'm oversimplifying it, but long and short, that's why we use this information and what we have to consider. So this is, again, just, some of the supplements, things that we can use, things that we can do. We talk a lot about different doses of zinc and the various nutrients that are contained therein. The Beckman classification system, we don't have any treatment for really no AMD or even early, because you can't see it on an OCT or wherever else. So basically it's like saying you found a lump in your breast. We're going to wait until it gets bigger before we're going to recommend antioxidant support, surgery, whatever. It makes no sense. It makes no sense. Let's do it. You already know what you're doing because you're hitting the beta carotene and the carotenoids with lutein and zeaxanthin. And, we can really augment disease in all of these patients. There's tons of information out there on the health benefits of polyphenols in carotenoids and measuring them in patients. I want to get to one part and then we'll finish up here in a second. Lots of good studies, Yale University, Stanford University, all over the place, showing the correlation between macular, skin, and serum carotenoids and the benefits therein. So this is just one patient, 53-year-old man. He had a family history of AMD. Dad had many injections, anti-VEGF. Patient was pre-diabetic, hemoglobin A1C, et cetera, et cetera. So the patient did this particular type of scan for antioxidants, and he shot a number of 26,000, which is not great. It is not failing, but pretty close. So what we want our patients to do is have enough antioxidants to really completely support anything that their body can throw at them or anything that their exposome can throw at them. That's what we want in our patients. We want it in every patient that comes into our practices and into our offices, because we are benefiting them systemically, which will ultimately benefit them in terms of their eye conditions. And not only do we have the ability to supplement them well, we also have the ability to measure it. And, you know, we have numerous dozens of optometry practices, you know, that we work with, that use this type of technology. So this will be the last thing, one of the last things I say. Maybe the next one's a little bit better. So this obviously is an OCT. And again, I'm not an optometrist. I just play one on TV. But look at the dates. We've got September 21st, 2020 to April 5th of 2021. So you see the drusen here. And, you know, the patient was scanned for their antioxidant carotenoid levels, antioxidants. And from September to April, they started on comprehensive antioxidant support, including lutein, zeaxanthin, you know, and the like. And you can see that this is not, you know, camera trickery or OCT trickery, but the drusen have almost completely resolved. This is a patient from Dr. Greg Caldwell. We always have to be thinking about that free radical and oxidative stress, and look to, you know, ensure that we are hitting numbers, hitting our antioxidant levels, and getting to a number in this particular way of measuring it. This 63,000 is actually excellent. 94% of people in the United States are in the grade level D or F failing levels, 94%. So 6% of people are in the green, which is good, all the way up to, holy cow, no matter what the world throws at you,